Start Jay now? Okay. So good morning. Today we will deal with one of the obstetric emergencies that we encounter, which causes maternal morbidity and mortality, especially in low resource settings. So one of the obstetric emergencies being postpartum hemorrhage. So globally, over 500,000 women die annually from causes related to pregnancy and childbirth. So it could be because of postpartum hemorrhage, it could be preeclampsia, it could be eclampsia or placenta previa. So any causes related to pregnancy and childbirth. So over 500,000 women die because of these pregnancy related causes. And of the various causes, obstetric hemorrhage accounts for 28% of all the direct maternal deaths and remains most common cause of direct maternal death. And 90% of deaths from postpartum hemorrhage were preventable. So today we will see how do we define postpartum hemorrhage. So we have primary postpartum hemorrhage and secondary postpartum hemorrhage, and what are the various causes or various risk factors for this condition, and once we encounter this condition, so how we should manage. And because we said that 90% of deaths from postpartum hemorrhage were preventable, so how can we prevent this grave condition? So to define, primary postpartum hemorrhage is loss of 500 ml or more of blood from the genital tract within 24 hours after delivery. So if there is loss of 500 ml after delivery, the two within 24 hours, we call it as a primary postpartum hemorrhage. Whereas secondary postpartum hemorrhage is blood loss which we encounter from 24 hours till 12 weeks post delivery. So that's how we define based on the time frame whether it is a primary or a secondary, because the causes tend to vary between the primary and secondary postpartum hemorrhage. And also this amount of blood loss can be a minor hemorrhage or a major hemorrhage. So if the loss is 500 to 1000 ml, we call it as a minor postpartum hemorrhage, whereas any blood loss more than 1000 ml is regarded as a major hemorrhage. And again in major hemorrhage we further subdivide into a moderate hemorrhage and a severe hemorrhage. So any blood loss which is between 1000 to 2000 ml is considered to be moderate hemorrhage, and if the loss is more than 2 liters we call it as a severe postpartum hemorrhage. And if you see the risk factors for postpartum hemorrhage, so these risk factors may present antenatally, that is few of the risk factors are present during her antenatal period, or some factors are because of the intrapartum factors. So care plans must be modified as and when risk factors arise so that this condition can be prevented. And women with known risk factors for PPH. So if a woman has already known risk factors, like suppose say she is a case of multiple pregnancy or she is a case of polyhydramnios. So in such cases, so women with no risk factors for postpartum hemorrhage should ideally be delivered in a hospital with a blood bank on site. So coming to the various etiological and risk factors, so we usually divide into four processes that cause this complication. So when it comes to the tone, so in conditions where there is uterus over distension, like in multiple pregnancy, or if a mother is having a big baby or a macrosomic baby, or if a woman has polyhydramnios where the amniotic fluid index is more than 24 centimeters, or in case if the fetus is having abnormalities like a severe uh, hydrocephalus. So in all these conditions, the uterus tends to be over distended and there can be alteration in the uterine tone leading to postpartum hemorrhage. So likewise, in conditions where we see there is uterine muscle fatigue, like if a mother has a prolonged labor or a precipitate labor, or else if a mother is a grand multi, this complication tends to be 20-fold increased risk. So if a mother is a grand multi, we should always be cautious. So because they have a 20-fold increased risk of this complication. And also this complication tends to be recurrent. So in women with previous pregnancy with this complication again can have a recurrence. So uterine muscle fatigue again leads to the alteration in the tone causing this postpartum hemorrhage. And also in cases where there is prolonged rupture of membranes, that is spontaneous rupture of membranes, so there is always a scope of ascending infection causing chorioamnionitis or uterine infection or endometritis. So again in this condition, this complication is again seen. And also in conditions where the uterus tend to be distorted or where there is uterine abnormality, like the presence of fibroids in the uterus, that is fibroid uterus, or else the presence of placenta in the lower segment, that is nothing but your placenta previa. So again in these conditions there can be this complication. And also if a mother has received any uterine relaxing drugs, like for example any anesthesia drugs, or if a mother is hypertensive or preeclampsia or a gestational hypertension and then she is prescribed this nifedipine, or else if a mother is on some NSAID drugs, or else if she has complication or complaints of preterm labor. So usually we give the beta mimetics, and sometimes even magnesium sulfate can also be given as a tocolytic, but most of the times magnesium sulfate will be given for severe preeclampsia and eclampsia. So if a mother receives for whatever reasons these uterus relaxing drugs, usually leads to postpartum hemorrhage. Coming to the other T, that is the presence of tissue. So we are done with the first T, that is alteration in the tone because of various conditions. Coming to the tissue, so this is nothing but presence of retained placenta or membranes, or presence of an abnormal placenta, that is either a presence of succinturate lobe or an accessory lobe. So again in these conditions there is, because of the presence of tissue, the uterus will be most often relaxed and cause this complication. And the other T is the trauma. So usually after a vaginal delivery, either a normal vaginal delivery or instrumental vaginal delivery, so there is every possibility that there can be a cervical tear or a vaginal tear or even a perineal tear, or sometimes even your episiotomy might also get extended. So whenever there is any tear, it leads to traumatic postpartum hemorrhage. And also extended tears at the time of cesarean section. So usually the incision that we give in the lower segment might get extended, especially if we are delivering a malpresentation baby, that is if a fetus is in the breech presentation or a transverse line. So we usually do a bit of manipulation to deliver the fetus, or else in cases of multiple pregnancy or a twin pregnancy where we have to do certain amount of fetal manipulation for the second twin, especially if the second twin is in a transverse position. Or else sometimes, even though in trimester, suppose if we are doing a second stage cesarean section where the head is deeply engaged, so there is every chance that the incision that we give might get extended. So with once the incision gets extended, it involves the uterine arteries and cause traumatic postpartum hemorrhage. And also the other cause being uterine rupture. So usually again this uterine rupture can be encountered in women with a previous cesarean section once they set into labor, or we are giving a vaginal birth after cesarean section. So in few percentage of the cases the uterus might give way, that is uterine rupture can occur especially in a scarred uterus. So the scar can be a previous cesarean section scar or a myomectomy scar or a hysterotomy scar. So any scarred uterus, there is always a risk of uterine rupture once they go into labor. So we need to carefully monitor them once they set into labor, and in case if we allow them for a vaginal delivery. And also in cases where uterine inversion is seen. So uterine inversion tends to be more common in women with high parity, or else if the placenta is fundally attached and even without separation we try to pull it, the fundus usually gets inverted or the uterus gets inverted, and whenever we give again excessive traction of the umbilical cord without being the placenta being separated, So we see this uterine inversion. So once there is a uterine inversion, again there can be a postpartum hemorrhage. And the other T stands for thrombin. So in women who have a pre-existing coagulation abnormalities, like for example, if a mother is a known hemophiliac, or if a mother has a von Willebrand's disease, so or else there can be a history of some coagulopathy or a liver disease. So because of the alteration in the coagulation profile, so these um, fits into the thrombin process and cause postpartum hemorrhage. And few of the conditions will be acquired in pregnancy. Certain conditions like severe preeclampsia or eclampsia, or even the presence of fetal death, usually initiates or triggers disseminated intravascular coagulation. So, and also women with preeclampsia with thrombocytopenia, that is nothing but your HELP syndrome. So that is hemolytic anemia, low platelet count, and elevated liver enzymes. So usually again in this condition, because of the alteration in the coagulation system, these patients will be predisposed to this complication. And also DIC can result from PET, or that is preeclampsia or intrauterine death, or sometimes even abruptio placenta or an amniotic fluid embolism. So in all these cases, usually we see that the mother will be predisposed to this complication. And also if a mother is on anticoagulants, for example, if she had a previous history of either a deep vein thrombosis or a pulmonary embolism for which she was prescribed this anticoagulants. So again, these are the women where we see this complication. And also if a mother has an antiphospholipid antibody syndrome, usually we give them or we put them on aspirin as well as low molecular weight heparins. So again, these are the women where we tend to see this complication. So coming to the preventive aspect of this complication, so whenever we are delivering any woman, we need to always go for active management of third stage of labor. So which is nothing but giving 10 units of intramuscular oxytocin once the fetal head is delivered, and we need to go for cord clamping, and the placenta should be delivered by this Brandt Andrews technique, that is controlled cord traction. So once the placenta is separated, we need to always deliver the placenta by controlled cord traction. So and doing a fundal massage. So these are the components of the active management of third stage of labor. So by doing this active management of third stage of labor, we can prevent many cases of postpartum hemorrhage. So the advantage of going for active management of third stage of labor is it reduces the incidence as well as the severity of postpartum hemorrhage, so thereby reducing the incidence of postpartum anemia, and thereby the need for blood transfusion is also reduced. So remember, always we need to go for active management of third stage of labor, and so that we can reduce this complication, or at least we can prevent the severity of postpartum hemorrhage, and also prevent the mothers from having postpartum anemia and the need for blood transfusions. So to minimize the risk of having this complication, so whenever we detect anemia during her antenatal period, so any antenatal anemia should be properly investigated and the woman should be treated appropriately, so that we can reduce the morbidity associated with postpartum hemorrhage. And remember, uterine massage prophylactically is of no benefit. And always remember, we need to always go for active management of third stage of labor. And for women without risk factors for postpartum hemorrhage delivering vaginally, so oxytocin 10 international units by intramuscular injection is the agent of choice. In case if a woman is going for a cesarean section, or the woman delivering by cesarean section, we need to give oxytocin. The dosage is 5 international units by slow intravenous injection. And also ergometrin oxytocin combination should always be given in women at increased risk of hemorrhage. See, now we know who are the women with who are at increased risk of hemorrhage. For example, multiple pregnancy or hydramnios, or a macrosomic baby, or a fetus with gross hydrocephalus. So those are a few of those women who are at increased risk of hemorrhage. So in those women, we need to always give a combination, that is ergometrin and oxytocin. And also in cases of in women who are having the cesarean section. So we can even go for giving intravenous tranexamic acid in the dosage of 0.5 to 1 gram in addition to oxytocin at cesarean section to reduce blood loss in women at increased risk of PPH. So in women at increased risk of postpartum hemorrhage, so in those women who are going to deliver vaginally, we need to always give this ergometrin oxytocin combination provided there are no contraindications for ergometrin. See, the contraindications for giving ergometrin usually include women having this heart disease or severe preeclampsia or eclampsia. So in those kind of women, we should always avoid giving ergometrin. So otherwise, it should be given in women at increased risk of hemorrhage. So again, use of intravenous tranexamic acid along with oxytocin can be given to reduce the amount of blood loss in women at increased risk of postpartum hemorrhage. And also carbitocin, that is a new agent, that is carbitocin 100 micrograms can be given as an intravenous bolus over 1 minute again in women at increased risk of postpartum hemorrhage. And so once any woman has this complication, the management includes, see, identification of the severity of hemorrhage. So we need to first identify what is the amount of blood loss. So again, your further management depends on the amount or the severity of hemorrhage. So because you need to know how many bloods you need to ask for. So identification of the severity of hemorrhage, and to identify the severity of hemorrhage, always remember that visual estimation of peripartum blood loss is inaccurate. So whatever you see, the blood loss is always inaccurate. So visual estimation of peripartum blood loss is always inaccurate. Instead, you need to always rely on various clinical signs and symptoms. So various clinical signs and symptoms should be included in the assessment of postpartum hemorrhage. So for assessing the amount of blood loss, so we usually use various tools, that is rule of 30, and the other rule is the shock index. So these are the tools that are used in emergency to know what is the amount of blood loss and the degree of hemodynamic compromise. So never ever just assess her blood loss based on the visual inspection. So always go for either a rule of 30 or a shock index to know roughly what is the amount of blood loss. So what is the shock index? So shock index is calculated as it is pulse rate by systolic blood pressure. So normally it should be anywhere from 0.5 to zero point 0.7. It is zero point 0.7, sorry. And if it is more than 0.9, so the woman needs an intensive therapy on admission. And if it is the value is more than 1, significant increase in rate of blood transfusion is required. So based on this pulse rate by systolic blood pressure, we can know which woman needs an intensive therapy and which woman needs a blood transfusion. And coming to the rule of 30, so it is again based on various clinical parameters. So if the systolic blood pressure falls by 30 millimeters of mercury, or if a woman's pulse increases by 30 beats per minute, or if her hemoglobin falls by 3 grams per cent, or if the hematocrit again falls by 30%, and if the estimated blood loss is 30% of normal. So based on these clinical parameters, we can again assess the blood loss and the need for blood transfusions. And also clinical features, what will be the clinical features based on the amount of blood loss? So if the blood loss is only 500 to 1000 ml, which most of the times the woman can tolerate because of the physiological changes that happen in the cardiovascular system in a pregnant woman. So most of the women can tolerate this amount of blood loss. So there won't be much change in the systolic blood pressure if the loss is only 500 to 1000 ml. So the symptoms can be a palpitation or tachycardia or a dizziness, which is usually regarded as a compensated shock. So most of the women can tolerate this amount of blood loss. But if the loss is more than 1000 to 1500 ml, then we see that there can be a slight fall in the blood pressure, that is 80 to 100 millimeters of mercury, and the woman starts to having symptoms like weakness, sweating, and tachycardia. So this is regarded as a mild degree of shock. And if the loss is 1500 to 2000 ml, so we see that there is a moderate fall in the systolic blood pressure, so it falls to 70 to 80 millimeters of mercury, and the woman starts to have a oliguria, and she feels restlessness, and we can see significant pallor. So this is regarded as a moderate degree of shock. And if the loss is more than 2 liters, that is a major postpartum hemorrhage, we find that there is a marked fall in the systolic blood pressure, and the systolic blood pressure will be hardly 50 to 70 millimeters of mercury, and most of the times with this amount of blood loss, so the mother mostly will be in a collapsed state or a hair hunger, or she goes into complete anuria, and so this is regarded as a severe degree of shock. So based on the amount of blood loss, we see changes in the systolic blood pressure and the various signs and symptoms. So whenever we encounter this complication, so always the most important, the first very principle is a communication and multidisciplinary care. And so we need to call for always help, so we need to communicate, and then the first thing in that we are supposed to do is resuscitation. So in case of minor postpartum hemorrhage, only minor postpartum hemorrhage, so we need to always have an IV access, that is one 14 gauge cannula should be inserted in case if she doesn't have, and then we need to always go for an urgent venipuncture. Venipuncture, we need wherein we need to draw 20 ml of blood for group and screen for her full blood count, and we are supposed to do a coagulation screen which includes fibrinogen as well, and her vitals, that is the pulse rate, the respiratory rate, and the blood pressure should be monitored every 15 minutes, and then even before your blood comes, because the amount of blood loss is a minor thing, so we need to always start her on command or start her on warmed crystalloid infusions, and then we need to always so this is regarding the minor postpartum hemorrhage. So all she needs is an insertion of an IV cannula in case if she doesn't have one, and then 20 ml of blood should be uh, taken for group and screen full blood count, coagulation profile, and of course we need to carefully monitor her vitals every 15 minutes and commence immediately a warmed crystalloid infusions. Whereas for a major postpartum hemorrhage, so always we need to assess this ABC, that is assess airway, breathing, and circulation. We need to keep the position of the patient flat and keep the woman warm using appropriate available measures, and we need to always transfuse blood as soon as possible if clinically required, and even before your blood is available, so we need to give up to 3.5 liters of warmed clear fluids. So initially 2 liters of warmed isotonic crystalloid should be given. So for a major postpartum hemorrhage, we need to always give blood, but even before your blood arrives, we need to give them at least 3.5 liters of warmed clear fluids, which usually includes 2 liters of warmed isotonic crystalloids. And then we need to carefully monitor the vitals. So temperature has to be monitored every 15 minutes, and ideally a continuous pulse, blood pressure recording, and respiratory rate should be done using a pulse oxy, ECG, and an automated blood pressure recording. So we need to have a continuous measurement of vitals in case of major postpartum hemorrhage, and always we need to always put in a Foley's catheter to know the what is the urine output, and ideally these women need two peripheral cannula, not one, and everything has to be documented. So what are the various fluids and the blood products or the blood products that she will receive? So crystalloids, 2 liters of isotonic crystalloids, and colloids up to 1.5 liters before the blood arrives. And the blood should be, if immediate transfusion is indicated, so emergency O negative, RST negative, K negative red cell units should be given. And in case she needs fresh frozen plasma, so which are the women who require these blood products? So if her prothrombin time or APTT are prolonged and hemorrhage is continuing or ongoing, we need to administer this fresh frozen plasma, that is the dosage of 12 to 15 ml per kg has to be given. So in case if the coagulation profile is altered, So the woman needs fresh frozen plasma, and if her platelet count is dropped, so she requires platelet concentrates. So administer one pool if hemorrhage is ongoing and the platelet concentrate is less than 75,000. So in case if the count is less than 75,000 and then the hemorrhage is continuing, still the woman is bleeding, we need to always give them the platelet concentrates. And cryoprecipitate should also be given again in women where the hemorrhage is continuing and the fibrinogen is less than 2 grams per liter. So in those women we need to administer 2 pools of cryoprecipitate if the woman is having hemorrhage and the fibrinogen is less than 2 grams per liters. So this is regarding the fluid therapy and the various blood products that a woman might need during a major postpartum hemorrhage. So there is a mnemonic which spells the actions suggested in the effective control of primary postpartum hemorrhage, that is hemostasis. So he AH is always help. So whenever you encounter this postpartum hemorrhage, so we need to always ask for help or call for help and quickly assess the hemodynamic status and blood loss and always resuscitate. So your resuscitation should be simultaneously done. So always assess the what is the amount of blood loss and you need to always start our resuscitative measures. And E is we need to know what is the etiology, whether she is having a atonic pph or a traumatic pph, and always give them embolics and always ensure that there is availability of blood. So ask one of your colleagues to ensure that there is availability of blood. And M is massage the uterus. So even before you load the oxytocin, you need to always massage the uterus and then go for oxytocin infusion, or else the first line of agent will be your oxytocin infusion, and then prostaglandins. Various prostaglandins are available. Some can be given intramyometrial, some can be given intramuscular or even per rectal as well. So go for prostaglandins. And then if if the hemorrhage is not stopped with various oxytocics like oxytocin infusion or by even giving prostaglandins, she requires shifting to the theater. So the purpose is we need to exclude whether there are any written products, and we need to even exclude whether she has any trauma. And bimanual compression should be done. And T is for tamponade or balloon or uterine packing, and A is for application of various compression sutures. And we will be dealing with the various compression sutures in the next slides. And AS is the systematic pelvic devascularization. So in spite of applying various compression sutures to stop the ongoing bleeding, we need to go for a systematic pelvic devascularization. And then the last resort will be a hysterectomy, that is subtotal or a total abdominal hysterectomy. But in case if you are in a facility where you have this interventional radiology, this interventional radiologist will can do this uterine artery embolization even before your hysterectomy. So in facilities where this is available, we can go for an uterine artery embolization, or otherwise to save the woman's life, we need to always go for a subtotal or total abdominal hysterectomy in case if a mother is not has not responded to various conservative measures. So management of bleeding, so we need to always determine what is the cause of bleeding. So this always requires a systematic approach. So first thing is E for establish the etiology. So the thing is uterus should always be examined to assess the tone. So we need to know whether it is an atonic PPH or a traumatic PPH. So always examine the uterus to assess the tone and ensure complete emptiness of uterine cavity. See that the placenta and the membranes have been completely expelled, and always go for examination of the uterus, cervix, vagina and the external genitalia to know whether there are any trauma or whether there are any tears. And inquire whether a woman has any previous history of clotting disorders, or a current clotting screen should be asked for. So these are the 4 T's quickly you need to assess. And then the palpate the uterine fundus and rub it to stimulate contraction. So when you massage the uterus, it stimulates the uterine contraction so that it helps in stopping the hemorrhage. And the other thing is you should always ensure that the bladder is empty. So we need to always put in a Foley's catheter and leave it in place so that the bladder is always empty in these cases. So initially you can always go for an oxytocin 5 international units by slow intravenous injection, and you may have, in case if the hemorrhage has not stopped, you can always repeat the dose. And the next line of agent will be your ergometrin, that is 0.5 milligrams, again by slow IV or IM injection. So as we have discussed, this injection is contraindicated in women with hypertension and various cardiac diseases. And oxytocin infusion should be given. The dosage is 40 international units in 500 ml isotonic crystalloids at a rate of 125 ml per hour. So unless fluid restriction is necessary. So this is the first line of drug that is used in the management of postpartum hemorrhage. So you can give oxytocin slowly 5 international units either by IV injection or as an infusion, that is 40 international units in 500 ml isotonic crystalloids at a rate of 125 milliliters per hour. So in case if the hemorrhage is still continued, we need to go for carboprost, that is a prostaglandin. So the dosage is 0.25 milligrams by intramuscular injection, and the dose can be repeated at intervals of 15 minutes. So maximum of 8 doses can be given. The only thing is this agent is contraindicated in women having asthma, because this is again a prostaglandin which can cause bronchospasm. So this in women who has a history of asthma, so this agent should ideally be avoided. And we have another prostaglandin, that is PGE1, that is misoprost. The dosage for postpartum hemorrhage will be high, that is 800 micrograms, can be given sublingually or even parectally. So these are the various oxytocics that should be given. So remember, always, even before you give any drugs, always massage the uterus because it will help in stimulating the contractions, and always ensure that the bladder is empty. So always keep a Foley's catheter and leave it in place. And you can give oxytocin either by slow IV injection, that is 5 units, or can be given as an oxytocin infusion, and then you can even go for ergometrin 0.5 milligrams in case if a woman does not have any contraindications for that. And carboprost in women who doesn't have a history of bronchial asthma, and misoprost can also be given. So these are the various oxytocics that can be given for the management of postpartum hemorrhage. So the next line of action, so in case if a woman is still continuing despite giving all these various oxytocics, we need to go for various compression sutures, that is the Lynch suture. So wherein we give or we cause compression of the uterus by applying this suture. So you need not know the exact details of this technique. So just remember that Lynch suture is done for the management of postpartum hemorrhage. So the idea is that the both walls of the uterus gets compressed and then the bleeding will be stopped. Or else we have various vertical and horizontal compression sutures. So either two vertical sutures can be taken in the body of the uterus, and two horizontal sutures, compression sutures, can also be given at the junction, that is at the level of cervicoisthmic junction. So even these sutures can also be given for control of this complication. And we have one more technique, that is chose multiple square techniques, wherein we give again a horizontal in the form of a square. So multiple, that is 4 squares technique can be given again to compress the uterus. So these are the various compression sutures that can be given to control this complication. But most often we do this Lynch suture as a conservative management for postpartum hemorrhage in case if a woman has not responded to various oxytocic measures. And the next thing is we need to go for systematic pelvic devascularization. So what does that mean? So we need to go systematically, we are devascularizing the uterus so that the bleeding will be stopped. So initially we can always go for the uterine artery ligation. So that is the area where we need to ligate the uterine artery. So one of the measures or steps in the systemic pelvic devascularization is uterine artery ligation. or else we can even go for infundibulopelvic vessel ligation. So that is the tubal branch of the uterine artery usually is ligated. So this is one step for devascularizing the uterus. Or else we need to go for the internal iliac vessel ligation, because you very well know that the uterine artery arises from the anterior branch of the internal iliac vessels. So that is the site wherein we can go for the internal iliac vessel ligation in case if the woman has not responded to the above measures, that is uterine artery ligation or your infundibulopelvic vessel ligation. So in case if there is expertise in doing this internal iliac vessel ligation, we can always go ahead with doing this procedure. So again, so this is a repetition again. So always ask for help, assess quickly the hemodynamic status and the amount of blood loss, and always you need to start your resuscitative measures. So you need to insert the cannula, you need to give your isotonic crystalloids even before your blood arrives, and we need to establish quickly what is the cause, whether it is an atonic postpartum hemorrhage or a traumatic postpartum hemorrhage, because the management varies. So in case if the uterus is atonic, we can give various oxytocic uh, agents like oxytocin, ergometrin, prostaglandins, be it misoprostol or carboprast. So in case if it is a traumatic postpartum hemorrhage, so in these cases the uterus will be completely retracted or contracted, and we need to suture the various tears in case if she has. So a perineal tear or a cervical tear or a your extended episiotomy tear has to be sutured. So that management differs based on the etiology of her postpartum hemorrhage. And so various oxytocic agents has to be given in atonic postpartum hemorrhage. And in case if a woman is not responding, so she requires shifting to the theater to exclude, in case if you have any suspicion that there are any retained products of conception, or if your trauma, if your tears have extended deep, so you need to always shift to theater, examine her properly and suture. So and then tamponade is one way of arresting the postpartum hemorrhage, and we can apply or go for various compression sutures, be Lynch or whatever, and then go for systematic pelvic devascularization, and then the last resort will be going for a hysterectomy. So that's how we manage a case of primary postpartum hemorrhage. That is in case where there is loss of blood that is more than 500 ml within the first 24 hours. So coming to the secondary postpartum hemorrhage, where the bleeding is anywhere from 24 hours till 12 weeks post delivery. So the causes and diagnosis are different from the primary postpartum hemorrhage. So the causes being mostly it is endometritis, or it is retained products of conception, or whenever there is subinvolution of the placental site, and rarely this secondary postpartum hemorrhage is because of the pseudoaneurysms or AV malformations. Of course, these are very rare etiological factors for a secondary postpartum hemorrhage. So all that we need to do is whenever a patient comes with this complaint, so the patient can come to us maybe after a week or even 10 days or sometimes 2 weeks, whatever. So whenever a woman comes to us, so we need to always take a high vaginal swab and endocervical swabs, because abnormal vaginal microbiology is seen in almost 52% of the cases. So we need to always take a high vaginal swab and endocervical swab, and based on the sensitivity we need to always treat her. So meanwhile antibiotics should always be given, because most often endometritis is the cause of secondary postpartum hemorrhage, and also to know whether there are any retained products of conception. So we need to always do an ultrasound to rule out whether she has any retained products within the uterus. And in case if there are no features of endometritis and if the uterine cavity is empty, and if we are suspecting any presence of pseudoaneurysm or an AV malformation, we need to always do a color Doppler to identify these factors. So coming to the management of secondary postpartum hemorrhage, so the ideal regimen will be giving a combination of clindamycin and gentamicin. And in case if we have found any retained products of conception on ultrasound, we need to always go for a surgical evacuation. And of course the procedure should be a gentle, because in cases of postpartum uterus there is always a chance for causing perforation. So we need to do very gently this surgical evacuation of uterus in cases of retained products of conception. And then in case if we have encountered any malformations or pseudoaneurysms, we need to go for an arterial embolization or else balloon tamponade in case if she is having ongoing bleeding. So that's how we deal with secondary postpartum hemorrhage, because most often endometritis is the cause. We need to always give them a combination regimen of antibiotics, and if RPOC are seen, we need to go for a surgical evacuation of uterus. So really rarely we see the causes like pseudoaneurysms or AV malformations wherein we need to go for an embolization procedures. So in a gist, the various postoperative complications after having postpartum hemorrhage, be it atonic or as a secondary or a traumatic postpartum hemorrhage. So if the mother is not resuscitated immediately, especially after a major postpartum hemorrhage, she goes into multiple organ failure and maternal death. And venous thromboembolism can also be a complication of postpartum hemorrhage. And again, in cases of massive or major postpartum hemorrhage, these women might go into hypopituitarism, that is Sheehan's syndrome, where especially the anterior pituitary gland is at risk, and the various hormones that are released from the anterior pituitary gland will not be secreted. So she goes into Sheehan's syndrome. So wherein the mother will have failure of lactation, the loss of axillary hair, pubic hair, and all symptoms and signs of hypothyroidism. So whatever hormones that are released from the anterior pituitary will be lost. And especially in cases of traumatic postpartum hemorrhage or otherwise even in atonic postpartum hemorrhage. So there is always a risk of causing damage to the urinary tract. So we might damage a bladder or a ureter. So urinary tract injuries can also happen, and even resulting in a genitourinary fistulas. And rarely we even cause bowel injuries or GIT fistulas as well. And pelvic hematomas will be encountered in cases of traumatic postpartum hemorrhage. And likewise vascular injuries, and especially if you are going for a curettage for retained products of conception. So uterine synechia can be expected. So the presence of uterine synechia is nothing but your Asherman syndrome. So this complication can occur especially if you are going for an evacuation in a postpartum uterus. And sepsis can also be a complication. And in women who have where the hysterectomy is required, uh, the mother might go into various psychological consequences because of the loss of her uterus. So these are the various postoperative complications that can happen after this deadly or a major postpartum hemorrhage. I hope I am clear with this topic. Thank you.